A very good morning, one and all. I am Mrs. Aarti Vishal Mittal, Joint Secretary, MSSI Hyderabad Chapter. Welcome you all on this Sunday morning. Today, we embark on a thought-provoking journey through a panel discussion with esteemed doctors, delving into the complexities of multiple sclerosis. We are honored to have a team of experienced and renowned doctors. We are grateful for their willingness to share their expertise accumulated over years of practice to enhance our understanding and management of MS. Notably, this is the first national event for World MS Day from MSSI Hyderabad chapter. And it's my pleasure to invite Mrs. Sudha Nyagapati, a distinguished committee member and GC member from MSSI Hyderabad chapter, to welcome and introduce our illustrious panelists who have graciously taken time out to join us on this enlightening Sunday morning. Sudha, can you please introduce the doctors?
Thank you, Aarti. Good morning, everyone. So let me introduce our dear Dr. Sudhir Kumar. Yes, Dr. Sudhir Kumar is currently working as a consultant neurologist at Apollo Hospitals, Hyderabad since 2004. And prior to that, he was with Christian Medical College, Vellore, as lecturer and consultant neurologist. Dr. Kumar completed his medical degrees of MBBS, MD Medicine, and DM Neurology at CMC Vellore from 1989 to 2001. He is one of the youngest in the country to qualify as a neurologist at the age of 28 years. And he has experience of over 25 years in managing patients with various neurological disorders that include multiple sclerosis, epilepsy, brain stroke, dementia, migraines, and neurocritical care. Dr. Kumar has over 125 published research papers in peer-reviewed national and international journals, along with multiple book chapters, monographs, paper presentations, and clinical trials. He is passionate about teaching, educating patients, and public at large. He has about 88,000 followers on Twitter. We are all excited to hear your insights, Dr. Sudhir. Please take over.
We cannot hear you.
Dr. Sudhir, you are on mute. Please unmute yourself.
Javid ji, can you communicate to him that he is on mute?
He's not on mute, but we can't hear him.
Yeah, he is. Video is also on.
Oh, there's a pin sort of a thing.
Good morning, everyone. This is Renuka. Maybe we can request Dr. Sudhir Kumar to log out and log back in with clicking the icon join with computer sound, because I don't see his mic, so he's probably not audible. Thank you.
Dr. Sudhir, you may sign out, then log in again. I think there is some connectivity issue from your side.
Still can't hear.
Javed, I think you should unmute doctor or make him a co-host.
He is already co-host.
Doctor has messaged in the chat that the host has muted everyone.
No, we can see his video and audio is on.
I'm calling him on. Javed, Dr. Sudhir Kumar is saying that he has unmuted himself, but what message he's getting that host has muted everyone.
No, now we are able to hear you. Earlier I muted all, but now he's unmuted and his video is on.
Hello, doctor. Can you say something? No, we can't hear you. So we'll solve this problem. Hi, Renuka, how can we do this? Or he has already logged out and
In the
logged in
meantime,
again.
I think we can go with other doctors.
You please take this. Sudha, can you introduce Dr. Ritu? I'll just call doctor and then.
Yeah.
Javed, I'm sending his number to you. You call up and connect. Okay.
Okay, fine.
Should I go ahead with Dr. Ritu Agarwal's introduction?
Yeah.
What? Yeah. Okay. Welcome, Dr. Ritu Agarwal, to our forum. So, Dr. Ritu Agarwal is a seasoned ophthalmologist with practical work experience in various departments of ophthalmology. She did her MS Ophthalmology from PGIMER, Chandigarh, and is currently working as a senior consultant eye surgeon at Swarup Eye Center, Hyderabad. She has also been associated in the past with Sadhuram Eye Hospital and Medwin Hospitals. With 30 years of experience, she has performed over 5,000 surgeries with a high success rate. She specializes in corneal and cataract surgeries. A warm welcome to our forum today, Dr. Ritu. The stage is yours now.
Thank you, Sudhaji, for the wonderful introduction. Very good morning to all of you. To begin with, I would like to thank the esteemed members of the Multiple Sclerosis Society of India Hyderabad chapter for inviting me to this august forum. And I hope I'm audible. I'm just going to share my screen now. I'm audible?
Yes, doctor.
Thank you. So we are talking on multiple sclerosis today, and the focus is on the diagnosing of early symptoms and the diagnostic roadblocks or the challenges faced to make these diagnoses. I would like to tell you all that the eye is the window to our body and health. We can diagnose many systemic diseases just by peeping inside one's eye. The eye is that powerful. The retina and the optic nerve are actually direct extensions of the brain, and the eye is the only place in our human body where we can visualize part of the central nervous system in real time. Now, multiple sclerosis, as we all know, is a demyelinating disease. And you mentioned the word multiple sclerosis in front of an ophthalmologist. And the next two words which flash in our minds are optic neuritis. I will tell you in a moment why. But first, let me list out the various eye symptoms that can present in a patient of multiple sclerosis. The patient can present with blurring of vision, grayed vision, or decrease in vision. This is generally a unilateral presentation, that is, only one eye is affected. He can also complain of temporary blindness in one eye. There is loss of normal color vision, issues with depth perception, loss of vision in parts of the visual field, loss of contrast sensitivity, uncontrolled horizontal or vertical eye movements called nystagmus. There is opsoclonus, diplopia or double vision. There are painful eye movements. Patients often complain of headaches, mostly in the frontal region, and periorbital pain. Rare cases, patients might even present with facial palsy or even uveitis. And there is also numbness and or pain along the distribution of the trigeminal nerve. So now coming to my arena, that is the optic nerve. We all know that the optic nerve carries visual information from the retina to the brain. And optic neuritis is a condition affecting the optic nerve. Optic neuritis is an acute inflammatory demyelinating disorder of the optic nerve. What is important is that it is a common early manifestation of multiple sclerosis, providing a potential early opportunity to screen for and diagnose multiple sclerosis. Around 15 to 20% of the multiple sclerosis patients present initially with optic neuritis. So this is one of the first presenting symptom. And 75% of patients with established MS will experience at least one episode of optic neuritis in their lifetime. Coming to optic neuritis, it is generally seen more commonly in females around 20 to 50 years of age. The patient presents with blurred, decreased vision, generally in one eye. There is painful eye movements, frontal headaches, altered color vision, especially the red color, which appears to be dull or washed, altered contrast sensitivity, and there are visual field defects seen. Now, why is early diagnosis important? Early diagnosis of MS and initiation of treatment is important for preventing or minimizing long-term disabilities of the disease, for slowing down the progression of the disease, to improve the quality of life of the patients, to bring down the healthcare costs, and most importantly, to reduce the annual relapse rates by at least 29 to 68%. Now, coming to the entire focus of this presentation is the major barriers which prevent early MS diagnosis. Diagnostic delays persist even in the best of the healthcare systems. Early symptoms are so subtle and intermittent that they make early diagnosis difficult. The major barriers in preventing early diagnosis are, you will be surprised by this, is limited awareness of the MS symptoms and that the eye too can be involved amongst the general public and even healthcare providers. Non-availability of specialist doctors like neurologists and radiologists in some areas, or in fact quite a number of areas in our country, especially the rural areas. Requirement of specialized medical equipment like MRI machines, OCT machines for diagnosing MS may not be readily available in many places to aid early diagnosis. Many diagnostic tests required for diagnosis are costly and may deter the patients, thereby prolonging time for establishing diagnosis and starting the treatment. Cost of traveling to places with facilities adds to the economic burden. The whole journey of undergoing so many tests and then the actual diagnosis per se can lead to depression and anxiety in many patients, and the stigma attached to the disease often leads to loss of follow-up. All of this leads to delay in seeking medical attention and diagnosis. Now, coming to the ophthalmological challenges, the early symptoms of optic neuritis, which points towards multiple sclerosis, like blurred vision or double vision, are also caused by various other conditions like cataract, glaucoma, even migraine. So, all these conditions have to be ruled out. And all of this takes a lot of investigations to be done, costing time and delays in further challenges. Spectral domain OCT is required to pick up subtle optic nerve swellings. We have to work alongside a neurologist and a radiologist to arrive in a definitive diagnosis. Most important, there is lack of awareness that the eye too can be involved in multiple sclerosis. And one of the most challenging diagnosis is that when the patient has an attack of optic neuritis, for the first 1 to 2 weeks, there is decrease in the vision. But even after the first attack, there is spontaneous visual recovery by 4 weeks. The vision is back to near normal. Now, once the patient recovers vision, he or she clearly thinks we are making unnecessary fuss advising so many tests, and most of them are lost to follow up. And then they turn up again with a second event or when the systemic symptoms start appearing. By that time, a lot of time is lost. Crucial time has been lost. New research has focused on novel biomarkers in ocular fluids as well as eye tracking movements. Hopefully, in future, we will have more sensitive, non-invasive, cost-effective tests for early detection of multiple sclerosis, thereby reducing the time gap to starting therapy and diagnosis. Thank you. Click to exit. कहाँ पे करना है? So I hope I made certain points clear.
Yes, doctor, it was wonderful and it was very clear, and everyone could understand it very nicely.
Thank you.
Dr. Sudhir, are you in?
He's here.
Okay,
But
then
I don't know if he could hear you. Dr. Sudhir, are you there? Are you able to? Oh, okay.
okay, then can we go ahead with Dr. Namita Singh, because I've not got any message also from him.
What happened, Javed?
I asked him to log in again. He logged in again, but again the same problem started.
But we checked all his sound and everything. It was coming okay,
Yeah.
no?
Yeah.
फिर एक बार ये बोल दो log
Dr.
out करके.
Sudhir, we are able to see you, but not able to hear. There's some problem in sound. I don't know.
Can he join from his phone or
From our
something?
side, there's no issue. I think from his side,
Maybe he can join from his phone.
Dr. Sudhir, you may, are you using the mic so you can remove the mic and you can directly? Problem is with mic, I think so.
If there's a problem arising, can we have Sudha introduce Dr. Namita Singh?
Good afternoon, Dr. Namita. Welcome to our forum. So about Dr. Namita. Dr. Namita Singh has her PhD in psychology Her specialization is in neuropsychology. She has been fortunate of having work experiences in Defense Institute of Psychological Research, one of the premium labs of DRDO, the Army Hospital Delhi Cant, in the psychiatry department in the Government Medical College and Hospital Chandigarh, consultant and faculty member in premium universities in India and South Africa. Currently, she is a consultant psychologist at Apollo Hospitals, Jubilee Hills, Hyderabad. Her areas of interest are neuropsychological rehabilitation of traumatic brain injury cases, CVA, that is stroke, behavioral and cognitive management of individuals with mental handicap, counseling for substance and behavioral addictions, management for clients, family, and caregivers, post-traumatic stress disorder, psychological intervention and management of HIV seropositive cases, suicide prevention and depression management, and stress management. She has been very actively involved in various public mental health and hygiene awareness programs. Over to you, Dr. Namita.
Thank you, Ms. Sudha, for the wonderful introduction. Namaskar and good afternoon, everybody. Thank you for joining on a Sunday. And it's a privilege to be here talking to many of the esteemed panelists and the members of MSSI India. So I would like to talk about two things specifically. The first, psychological symptoms, what we see commonly across the board in a linear way, but not necessarily in a universal way. So it is commonly includes subtle changes in mood, cognition, that is our intellectual ability to respond to our attention, concentration, motivation. And some of the common ones are, can you please change to the next slide? Sorry, before that, we'll just talk about two things. The first, psychological symptoms, what are they commonly, which we have seen, faced, or endure, and what are the systemic barriers? How do we tackle them? The third key point which I want to mention is importance of mental well-being in the unofficial workplace, also known as life, because this is just not related to MSI. If our mental well-being is in place and we have the systems providing that support, many of us are more smoothly apt and have the better coping strategy. Next slide, please. So the common first psychological symptoms, as I would repeat, they are universally present, but not in a linear way. Any individual diagnosed with MS condition will not necessarily have in the same systemic progressive way. Somebody can have just depression and somebody can have irritability and mood swings. So when I talk about depression, common psychological response on knowing about the diagnosis. It can be due to brain changes or as a reaction to diagnosis or the symptoms. Then we have the cognitive impairment, which we talk about difficulty in decision making, difficulty in planning, difficulty in having the motivation to do certain essential tasks around it. Memory, in some cases, gets impacted initially also. The ability to attend, when I say attend, pay attention to a stimulus or conversation may get diminished. Then we have the fatigue part. Fatigue is not just the physical fatigue, but it is the mental fatigue. The overall ability to do small conversations or engage in reading, trying to do a new task takes a toll. And it is usually embodied also as a physical exhaustion. It can be early and a persistent symptom. Anxiety. Anxiety can be again just due to the diagnosis, or it can be also what may happen in the future. How am I going to survive this condition? It can be also related to the neurological changes in the brain. Then we come to the emotional lability. It is also called the pseudo-bulbar effect, which includes there may be uncalled sudden laughing, crying, sudden spell of sadness, and the person may be able to snap out of it on its own. It can be caused by the lesions in the specific brain areas, which deal with our emotions, our memory systems, and our overall social linking of behavior to the bigger community. Mood swings can be due to, again, brain lesions or as a response to fatigue and functional limitations. These symptoms can sometimes appear before a definitive MS diagnosis is made, especially in clinically isolated syndrome, which is many times a first neurological episode suggestive of MS. Right away, many individuals are not diagnosed by MS, but it may be a clinical isolated symptom presentation 3 years ago, and then there's a repeat after 6 months or a specific duration. But if these symptoms have been occurring in a sequential or non-sequential form, it can be indicative as the first psychological symptoms of multiple sclerosis. Next slide, please. What challenges many of the individuals face who have been identified with multiple sclerosis? As you can see, there is societal stigma and exclusion, which includes that we ourselves feel inhibited, that my life quality or my life circumstances or choices are not so open now, and the disclosure to the bigger community or family members becomes an inhibitory process. So it is a both way, two-way road, where the individual may feel that isolation and doesn't want to mix or engage because of the diagnosis of multiple sclerosis. And there may be also exclusion by the bigger community members because many of the general population do not know enough information about MS condition. Many of us, out of fear, assume and have stereotype biases around that any disease is infectious or it can cause deterioration in life quality. So the community at large or family members in the bigger family system may not want to engage with the person identified, diagnosed with MS. As we know, healthcare, whichever approach we are taking, it involves very high exuberant cost. Now in many developed countries, disease modifying techniques, therapies are being used. But there has been a data analysis on that even when in high economically sufficient developed countries, many people opt out of the DMT therapies because the cumulative cost is very exuberant. And when we talk about treatment delays, as Dr. Ritu also mentioned about it, there are not enough specialists to provide the adequate support. A lot of healthcare professionals are not aware fully about the prognosis, diagnosis, and the treatment plan effectively of this condition known as multiple sclerosis. So many times we do see cases where people may have the symptom presentation, anything is specific, but over a period of time, it results into delay in the actual treatment plan and actual approach to the formal systematic treatment approach. As I've earlier mentioned, depression, anxiety also makes the mood or the mood of the individual to isolate, because the individual is trying to figure or at times feeling so low in energy, he doesn't want to get included or join in different events, and that results into further ability not to engage. When I say limited support, mental health issues are generally overlooked, unidentified, underdiagnosed, and do not have enough professionals to give the adequate support. Next slide, please. As I mentioned, related to the systemic challenges, widespread stigma. All across the world, data shows there is stigma quite commonly seen in different scenarios. Social isolation, which partially I spoke about it, misunderstanding, misinformation can lead to withdrawal of support. Community support gaps are quite commonly seen. Even the best intended people are not available to give the adequate support as a speaking voice for the people enduring the condition. And many times the individuals affected, inflicted by the disease condition do not have the reach out to forums or societies or government information, because MS is still a very raw and a low priority condition in healthcare systems across the world. And many times when, even if the medical professional is available and support system is there, the fear of knowing or accepting the eventual process of progression of the disease makes the individual hide the symptom presentation. So there may be 2-3 sequential symptoms in the different body organ systems, but the individual may just report the 2 or of main of them and think rest of the symptoms, oh, that's just because I was tired, so I couldn't go for my walk, or I couldn't complete the reading part because I was having a headache. But if it is commonly persisting, these lack of adequate full reporting leads to, again, a hampered and a delayed holistic treatment approach by the specialist. Next slide, please. As I mentioned earlier, access to healthcare is very limited. Just for our data reference, it's not about our country only. Across the world, mental health professionals are a scarce breed. So again, to contextualize it, in India, our country, for 2.5 lakh people, there's one psychologist available. And when we talk about psychiatrists or counselors, overall, for 10,000 people, there's one psychiatrist available. And in rural area, that number goes to 40 to 50,000 people. And we know predominantly India is still a semi-rural landscape of communities. Language barrier, accessibility to adequate professionals. Most of our general population does not know or has access to insurance. When even the health insurance is provided, many of us do not understand the intricacy of application of the payment process. So people end up buying insurance, but when the need be of claiming the required claims, it becomes a long barrier and a systemic delay to really get funds and support in adequate time, which again enhances the systemic gap of delayed diagnosis, delayed accessibility, and scarcity of specialists, which leads into the person having more depression or more symptom prominence relapses frequently. Next slide, please. Part of it I've already mentioned, but this is the third aspect of the objective of the presentation which I had made. whatever scenario, it is important to reach out for psychological support. Telling somebody that I can't cope, or I have crying spells, or I am feeling very worried, fearful, my sleep is getting disturbed due to the persistent thoughts of what will happen, is not a weakness. It doesn't make us less of a human being. So initially, when depression and anxiety support systems through a group discussion with the people impacted by the condition, or to close understanding mature friends or social circle, helps the person to disengage partially from the constant worry, which becomes a de-stressing factor to the nervous system, which leads to a better mental coping strategy and less strain on the neurotransmitter in the brain system. Societal attitudes specifically, there may be a lot of odds, or there may be a lot of difficulties, but if we keep the positive value system and a self-care goal, self-regulation process, society cannot be a hindrance in our day-to-day activity, or ability to make a living, or ability to engage with some like-minded people, whether at professional level or personal level. Impact of chronic illness, we all of us know chronic long-term depression and anxiety is a prime factor for depleting our immune system. We have seen it through the ages. Now we more know about it due to the recent pandemic. And we know individually people who have been chronically stressed with low mood and anxiety, they do get more diseases in their system, not willingly, but because the system, body systems are compromised. Next slide, please. This is a very important aspect, and I'll take few minutes to just explain it. Please let me know if I'm short on time. And I'm not going to go into the technical specificity, but there is a subfield in psychological therapy, and which specifically deals with psychoneuroimmunology. There is enough research to say that depending on how our brain health is, how our mental state is, will define the longevity of our life, the quality of our life, and the coping strategies which we will use in different stages of life. Just to simplify it, and I'm not going to detail in it, we know we have cells in the body, in the brain, and it is a small structure which really carries a lot of intelligence. And if I have to explain, as you can see on the slides, some of the cells are our soldier cells, and some of the cells are our cells who carry out message. So depending on how our mental state and how our attitude is, these cells also, they get activated or deactivated. In brain system, there are different processes. One of them is that, like when I say the cells of the body are continuously talking to the brain structures, something called as sympathetic nervous system. So if I'm feeling emotional pain after watching a sad movie, or watching a sad content, or a worrying content, my cells will get anxious around certain things. It is very important to keep that communication smooth and easy. Every impulse of the mind, every thought is conveyed to each cell. It may look very illogical, but it does happen throughout the body. They are greatly influenced by the states of the mind, the state of the brain. If there is confusion, anger, depression, or other negative emotions in the brain, mind, they are telegraphically transmitted through the nerves to every cell in the body. The soldier cells become struck. They are weakened and inefficient. When a person is unhappy constantly, the life force is not operating properly. healthy vitality is at a low ebb. One should understand the goal of life is to think and feel positive in spite of the challenges to survive better. Positive thoughts trigger happiness down exactly to each cell level. Then the body's function and can operate efficiently. Positive thoughts support vitality and good health. Next slide, please. As you can see, and most of us are aware for it, so I wouldn't spend much time on it. But, and again, they don't have to be in the same linear process, but make it a point that you are able to, or all of us are able to give certain time of our day to each of this activity, including the most important I want to emphasize is in today's time, most of us are on the go, the food on the go, the work on the go, the meeting with the friend on the go. We don't need to constantly challenge our system and keep sending, oh, I'm late here, I'm running there. The day will be again tomorrow. There will be breath again tomorrow. But the toll it takes on our system is irreversible. And that's the main message I want to send through this. Learn to say a no. Because it's not that you don't love or respect other people, but it is because you owe it to your life and your quality of life. Last slide, please. Sorry, this is the second. Many of you may be aware of it, but I just wanted to refocus. We don't need to be the star of the universe. We just need to be stars for ourselves. And some of you may feel like using these techniques. I'll only repeat the last thing. Continuous self-renewal and self-care is the key to having a good quality of life. So please pay attention and time to your mental, physical, spiritual, and emotional well-being. Last slide, please. I would like to thank you by just using these quotes. I'm not going to read them out. They are on the screen. Do whatever you do and do it well for yourself. You are not there to prove anything to the world. You're here to enjoy, live, breathe easy. Thank you so much. Take care and have a wonderful life ahead.
Dr. Sudhir Kumar.
Yeah, am I audible now?
Yes, yes, perfect.
Oh, great. Okay, fine. Finally. So, first of all, thank you to MSSI Hyderabad chapter for this opportunity to talk. And before me, Dr. Ritu and Dr. Namita have already summarized, a lot of aspects of MS. So that makes my job easier also. So if you look at MS, why still there are a lot of challenges in terms of diagnosis, and we are not able to diagnose people on time. So if you look at first, I have been practicing since the 90s. So first, we always said that in our country, MS is not there, or it is uncommon compared to the West. But the fact was that many cases were remaining undiagnosed. So that was the initial period. And then subsequently, in the early 2000s, we started saying that, okay, MS is there, but still we are not able to diagnose. So that there comes the lack of awareness and lack of resources. So lack of awareness among the general public also, because people are aware of diseases like cancer, heart attack, and stroke. Or even if you look at neurological disorders, then people are aware of epilepsy and migraine. But multiple sclerosis, many people haven't heard also. And the second thing is lack of awareness among doctors also, because as Dr. Namita pointed out, we have very few specialists in our country. So including psychologists and psychiatrists. So similarly, neurologists also are very few in the country. So it is impossible for the patients to directly approach a neurologist. So many times they have to go to general physicians, and general physicians somehow they lack adequate knowledge about MS diagnosis. So, and there a lot of time, is wasted or spent before they reach a doctor who understands MS. So that is the lack of awareness. And third is, in our country, we have to always talk about resources, because many people can't afford. And as you know that MRI is must for diagnosing MS, because all the diagnostic criteria, it includes clinical features, MRI features, lumbar puncture, and few other additional tests, because we need to rule out other conditions also. So if you look at, cost of doing all these multiple investigations, it may come to 25 to 30,000 rupees, and it is not possible for, I think, 50% of our population to afford it. And not only initially, but for follow-up also, those investigations are required. So I think these are some of the main things which delay the diagnosis of MS. And suppose, patients come to the doctors, still sometimes, even as, specialists or those who understand MS also, there also, it may not be possible to diagnose in the first step, because MS can have multiple symptoms. So Dr. Ritu nicely pointed out the optic neuritis part, the eye symptoms, but it can affect any part of the body. So if you look at, say, if we start with the brain, it can cause just simple headache, depressive symptoms, memory issues, and vision problems already has been discussed. If you look at motor symptoms, patients can have weakness of one hand, one leg, both legs and hands, numbness, tingling of hands and feet, bladder symptoms. So they have difficulty in controlling urine, and also sometimes pain. So it can be pain around the back, neck, and then so if you see, there are a lot of an imbalance while walking. So there are a lot of symptoms, varied symptoms which a patient can come with, and it is many times the doctors also fail to recognize that it could be MS. But now I think what has happened is, slowly and surely there is more awareness, thanks to MSSI and also media coverage, and more doctors are aware of it. So there is more awareness. So we are able to diagnose more number of patients. Even the availability of MRI has increased. So it is available in many parts of our country, even smaller places. So with the help of MRI also, we are able to diagnose conditions early. So definitely we have come a long way in the last 25 years in terms of early diagnosis, and the cost also has come down, and maybe not only cost, even the people can afford more. And then and once we look at diagnosis, the next part comes as treatment. And in terms of treatment also, we have come a long way. Initially we only had few agents like interferons and azathioprine, and now subsequently we are having more number of agents or medicines to treat MS, and many of the generic drugs have come. So now we have tablets. So earlier only injections, and that too they had many side effects. So now we have tablets, and they are generic. So cost also has come down, and even those who have very severe disease, or what we call, we have highly effective MS therapies also for those patients. So in terms of treatment options, we have many options now from the initial days. Cost wise also, we have options to suit many people. So we have come a long way. And then ancillary services like role of physiotherapy, occupational therapy, psychotherapy, counseling, psychiatric treatment, pain medicines. So all those things play a role. So definitely MS and ophthalmology. So MS requires a team of multiple specialists, and then we are able to get good treatment for most of our patients. And earlier, people, even now, if you go on to the literature search and see, because most literature comes from the West, and there somehow they have poor prognosis. But India is much better. If you look at our Indian patients, 95% of people do well. And the key is early diagnosis and early initiation of treatment. So when we do that, definitely, patients do very well. And 95% of patients are doing well. They're mobile, and they're able to do their jobs properly. So it's not as negative as what is portrayed in the literature, because literature is mainly from the West. And we do have a proportion of MS which is benign, where people do not have severe symptoms. And then we are also talking about cure. Cure means we use a term called as NEDA, no evidence of disease activity. So in some patients who have remained well for several years, there is a possibility of even stopping the medications. And so that is decided on based on the clinical criteria. But most important is in the period of, say, from the age of 20 to 40 years. So that is the period when the disease can progress. And if patients are able to get best treatment in the from 20 to 40, then the life after 40 can be very, very, easy and without disability. So I think this is what I had to say. And with this, I will stop and possibly we can take audience questions and queries. Thank you.
Sir, can you ask Sushma to come in?
Yes, yeah. I was hearing someone talk, so I thought probably, yeah. So I request Sushma, please, our committee member and advocacy group head for Hyderabad chapter, to moderate for our question answer session.
Thank you, Sudhaji. Firstly, I would like to thank all the doctors for giving you valuable insights on the topic of first symptoms of MS and what are the systemic barriers that we come across. And so we will take some questions now, doctors. I request audience to please post their questions in the chat box and we will take it from there. Thank you. The first question, this is to Dr. Ritu, ma'am. Ma'am, the eye challenges that we just that you have spoken about, mostly the blurred vision and double vision. So these are the most commonly seen challenges even during the first relapse or the subsequent relapses. So what do you think is the impact on the optic nerve as a result of multiple attacks? And is there any way to keep up with the health of the optic nerve from our side, because it is being affected multiple times in the relapses? So can you please suggest on keeping up with the health of it? You're on mute, ma'am.
Sorry. So generally, once we diagnose a case of optic neuritis in the OPD, even after the first attack, we refer the cases or we work in tandem with the neurologist, which is most important, because then they apply their criterias and they rule out systemic involvement or not. And so after the first attack of optic neuritis per se, the patients do well. In fact, in the natural, even if they don't take any treatment and all, the thing is that they do recover their vision back. So which lulls them into a false sense of security that no, we don't have MS, even though we talk about it to them. And then a lot of time is wasted when they have the second event. So like I said, optic neuritis generally happens in one eye. But many a times when we examine the other eye, we find evidence that probably this is the second event and the patient has had an event earlier. So it does insult the optic nerve, definitive about it. And treatment plans generally is, I would like Dr. Sudhir to highlight, because they are the ones who actually go ahead with the treatment to minimize the damage. So yes, even if we have subsequent attacks, the vision is compromised. And the loss of the visual field effects that we see is never really recovered, even though the vision recovers, but the patient does not actually recover fully the visual field defects or the loss of contrast sensitivity or the loss of color vision. That is compromised.
Thank you, ma'am. Dr. Sudhir Kumar, you want to add something here?
Yeah, basically, in terms of treatment, here also same rule applies. So as soon as the vision symptoms appear, patient should approach the doctor, and then we have to start what is called a solumedrol or methylprednisolone injections, and 1 gram daily for 3 to 5 days. That's the initial course, and generally we have to follow it up with preventive medications so that the next attack will not happen. Next attack can be optic neuritis or it can be any other symptom of MS also. So that's where the evaluation is important. And so as Dr. Ritu said, so we see the patients, we see sometimes patients may have only symptom of optic neuritis, but on the MRI, patient can get, we can see evidence of other parts of nervous system also affected. and that helps in deciding the treatment. So if we find that multiple parts are already affected, then we go for highly effective therapies. If we find that it's a very, a subtle or mild disease, then we have option of choosing milder forms of therapy also. So of course we discussed in detail with the patient, and it's an individual decision. We cannot make a general guideline. So each patient is unique, and we have to treat accordingly.
Thank you, doctor. And the next question is to you. This is about the rituximab. We are having a couple of questions on the chat, so I read out for you. How long can rituximab be continued as a MS person, considering its B cell depleting effects? Will prolonged B cell immunosuppression lead to potential issues? And what strategies could be adopted to manage pseudo relapse?
Yeah, so I think a very good question. So rituximab is commonly used in India, and we have to say that it is not one of the approved treatments. So when we say approval, we have agencies like FDA, and India we have DCGI, which approve medications based on the research. So in the research, somehow they could never prove the efficacy and in MS patients. But Indian neurologists, we have been using rituximab for more than 15-20 years. And it is not that rituximab is a new drug. It is used commonly for other autoimmune conditions also. So we know that the drug is safe in many indications, many diseases. And based on that data, we started using, and we have found that it is effective also. So most neurologists in the West also, they agree that it is effective in MS. But because they have more, big insurance coverage, insurance will not cover something that is not FDA approved. So they don't use in US and other European countries. In our country, the patients anyway, they have to pay on their own mostly. So that question of insurance coverage doesn't come. But here also, those who want insurance coverage, rituximab will not get covered generally. That is one part. Second part is rituximab is quite safe for long term. So we had another medications like say tisabri or natalizumab in its place, which had risk of fear of PML, progressive multifocal leukoencephalopathy. Even though we don't have any Indian cases, but in the world many cases have been reported. So that medicine had a ceiling of 2 years. We could not go beyond that because after that the risk of PML increases. In rituximab, there is no such fear. So that is why it can be used for a long time. Generally, the gap between two doses is 6 months, but we look at CD cell counts, and then CD19 and 20, and then based on that we decide the treatment. Regarding precautions, any immunosuppression, person has to be cautious about getting infected. So they should take care of avoiding infection. If somebody is having cough, cold, anything, so they have to stay away from that. While going out, it is still better to wear a mask. So those precautions, otherwise they are quite safe. And then, sometimes depending on the symptoms, we may have to monitor the blood counts and liver function tests. So otherwise, it's a fairly safe drug to use for MS.
Thank you, doctor. And two more questions on the rituximab itself. So the question is, what is the actual rituximab maintenance dose for MS persons? Is it 2 gram, 1 gram, or 500 mg?
No, I think, see, that depends on, as I said, it's individual decision. So we cannot make a general guideline. It is best to discuss with the treating neurologist. So that is a better answer here, rather than giving one kind of dose.
And another question is, I have taken 3 doses of rituximab injection. However, I have not seen any improvement in my condition. Should I go for my 4th dose?
Yeah, again, it depends on the individual decisions. So see, there are two things. One is that the purpose of these medication is not to improve the previous symptoms. These are medications to prevent relapses. So suppose something has already happened, for that only steroids, 5 days of steroids are effective. So they will help in the acute disease. So rituximab or natalizumab, or we have the oral therapies like dimethyl fumarate. So purpose of all these medication is to avoid future diseases. The current problem which has already happened, that will not improve with this medication. So for that, physiotherapy, depending on what the symptoms are. So those we have to work on that. So we have to decide whether any new relapses are coming or not. If new relapses are coming, then possibly we may have to think of changing the treatment. If there are no new relapses, just the previous disease is not improving, then we need to focus more on the physiotherapy and see what can be done.
Also, doctor, what is called a pseudo relapse and what strategies can be adopted to manage a pseudo relapse?
Yeah, pseudo means false. So the person feels that some symptoms have come, but if you examine the person and if you do MRI, we don't find any new lesion. So somebody is already having, let's say, old disease in the spinal cord or optic nerve, and then suddenly they may feel that vision is affected or there is weakness. But the old disease itself can sometimes cause more symptoms. So there we just have to give the treatment to relieve the symptoms. We don't need to give, say, another course of steroids, or we don't need to change the preventive therapy. So pseudo means false. There is no real relapse, and a lot of reassurance to the patient that it is not a real, because a lot of anxiety comes in that I was doing well, why this relapse happened. So counseling, reassurance, and then followed by treatment of the symptoms.
Thank you, doctor. And next question is to Dr. Namita, ma'am. Ma'am, talking about, you have spoken about the lack of motivation primarily seen in the beginning of diagnosis or subsequently. And then let's say, for example, a scenario where there are, the time is ticking, there are things lined up to do, and there is this fatigue sets in, dizziness sets in, there's confusion, and there is all these things, and it eventually leads to a feeling of helplessness and I'm not enough. So I think this is a more or less everyday thing for most of the MS persons. And what do you suggest to cope with this feelings?
Thank you, Shishma. It's a very prominent and important question. And what I would like to specifically say is, when there are multiple things lined up, and as you gave the sequence, it goes in a loop, we need to break the loop by just doing the basic minimum. Because instead of going for a walk or full session, we just say, okay, I'll walk for 10 minutes while I'm brushing my teeth or doing some activity. The key to disengage from the depleting energy or the low mood or the constant fatigue is take breaks, do things or activity in parts, and give your body and your brain. Hello, am I audible?
Yes, ma'am, you're audible.
Okay, sorry, some notification interrupted, so that's why I was wondering. So the small events of activity is enough for our brain neural pathways to change the track of inability, fatigue, anger, despair, whatever the negative emotions is. And I would say, as the second, third last slide was mentioned, whenever any individual is feeling overwhelmed or super anxious, the quick aid is deep breathing. Breathing is the key to disengage the overactivation of our worry mode to a relaxed mode. Like Dr. Ritu said, the eye is the gateway to a lot of health conditions to our body. Same way, breath work is the key to reach our brain's chemicals. The deeper we breathe, the more oxygenated blood is supplied to the brain system, which helps the basic neurotransmitters to change the tracks of negative to positive. Always it is said, like I'll use a common example. When people are angry or frustrated, or like, you just breathe easy. We have to make a conscious effort that we train ourselves that we will take 5 minutes every 2 hours to just sit, do nothing but breathe and focus on your breath. These are the small steps which we take to make the bigger changes. I would also advise, and it's a general common sense, nothing specific psychologically. If we look, and I'm using as an example, if I want to climb the base camp of Himalaya today, and I have not walked for last 20 years, it's an impossible task. But if I start walking for 5 minutes or 15 minutes gradually, I may develop the stamina in 2 years or 3 years' time. So instead of getting stuck in the helplessness mode,
whatever activity your brain is able to do in that particular time, disengage from that inactive mode to slight active mode, and then take it from there to the next little more active mode. Dislodging from the negative emotion, you may want to sit and watch some content, but give it a point that first I need to stretch my arms for 5 minutes, or I need to go and drink my water or get my supplement. So pairing the activities which enhance your well-being to something which is not so well at that particular day gives that added advantage to the system of motivation to get rewired and replenished to work effectively. Thank you.
Thank you. Thank you, ma'am, for sharing these wonderful strategies to cope up. The next question is to Dr. Ritu, ma'am. So this question is, ma'am, for someone who is diagnosed recently but without significant vision issues, is it still suggested to see an ophthalmologist? And if yes, what tests are needed?
Oh, yes. If a patient has been diagnosed with multiple sclerosis, I would definitely recommend that he or she goes and visits his ophthalmologist for the following reasons. One is that you just discuss out, we do a baseline screening for them, that what is the status of their visual acuity. Then we have advanced tests to really find out whether the optic nerve is actually involved or not involved, right? We can do OCT and all. Then because the initial treatment probably involves high doses of corticosteroids and all. So we would like to rule out disease entities like cataract or glaucoma, which are side effects of long-term therapy of corticosteroids, whether they are there or not there. We would even probably like to do visual fields and color vision to document a baseline normalcy, and probably talk to the patients and educate the patients that, look, this is what can happen to you ophthalmologically, and when you have to report to us if you have a blurry vision, you have pain in the eyes, because there are many symptoms, like even a patient of migraine, the symptoms of migraine mimics the early onset of optic neuritis. So more than anything else, it is the education that we would like to educate a multiple sclerosis, is to bring awareness, like this is what can happen with you, and then you see us immediately, because the treatment per se shortens the duration of the attack, which then long term is beneficial to the patient.
And one more question, ma'am. I have retrobulbar optic neuritis. Is it curable?
Retrobulbar optic neuritis is actually a presentation of multiple sclerosis, right? And the episode per se we can cure, and the patient does recover near total normal vision, right? But there are telltale signs which we can pick up that the patient's probably had an effect, has an attack of retrobulbar neuritis. And they also need to be educated and to be kept under a constant, regular follow-up under the ophthalmologist.
It is curable as per your opinion?
Yes.
Okay.
To some extent, yes.
To some extent. Okay. Renuka ji, please ask your question.
Thank you. This is a question for the neurologists in the panel. Would love to hear your insights on the fact that if the MRI shows no active lesions, which is a good thing, I'm assuming, but the physical manifestation of spasticity and fatigue is showing an increase. So why can anybody explain this? I mean, if there are no active lesions, then why are the symptoms getting aggravated? Any insights, any advice, any tips on how to handle this?
Yes, I think it's a very good question from the person who suffers from MS or any other neurological disease. So as you know, MS is a disease of central nervous system, which includes brain, spinal cord, and the optic nerves. And the central nervous system doesn't regenerate after the age of 7. So there is something called as plasticity of nerves, which is there up to the age of 7. And after that, if the nerves get damaged, they don't regenerate to normal. Which also means that if I get any disease of the brain or spinal cord or optic nerve, they don't recover. So suppose I have lost, say, 100 nerves in the brain, so they don't come back. Then the question comes, if they don't come back, then how do people recover? So still, we relearn because the brain has other nerves which start doing the function of the nerves that got damaged, and that is how. And then also we train our muscles by with the help of physiotherapy, which are weaker. So because of that, recovery happens. But the recovery will never be back to how the person was before the attack, because of the simple reason that the central nervous system neurons don't regenerate, and spasticity is a symptom of old disease. So if suppose I get a disease of the spinal cord or the brain, and when in the motor structures or the motor tracts, then as initial period there'll be the tone may be normal or even low, but as the person recovers, then the tone increases, and that is called spasticity. So spasticity doesn't mean active disease, it's a sign of older disease, and there we don't need any escalation of MS therapies. But to deal with spasticity, we have exercises, medications like baclofen, sometimes Botox injection. So there, we have many things to relieve the spasticity. But I agree with you that still many people, despite all the treatments, they don't get back to normalcy.
Thank you, doctor. One more question to you. This Dalstep tablet, is it used to control the progression of MS disease? And also the second part of the question is, I'm not doing physiotherapy. Will my disease progress or increase if I don't do physiotherapy?
The first question, Dalstep, I think it's a more of a symptom relief medication. It is not a specific MS treatment. So that way, so that it may improve the symptoms. The second part of physiotherapy basically means exercise. So the disease may not progress, but all of us should do exercises. Exercise has got benefits beyond the MS. So we know that there is a guideline of 150 minutes of vigorous aerobic exercises in a week, or 300 minutes of moderate. So if a person is, let's say, not has recovered fairly well, then they can even do vigorous activities like light jogging, swimming, cycling. Or if the person has mild disability, at least they can think of walking, which is a moderate exercise. And that is recommended is 300 minutes in a week, which is 5 hours. So that much is required, and this will reduce the risk of other problems. See, MS is a disease of younger age, till the age of 40 or 50. But after the 50, and as we know today that MS persons can expect to live long, maybe up to 70s, 80s, and 90s also. So that is why exercise will help in reducing the risk of heart attacks, strokes, and cancers, and also becoming overweight. So one need not do physiotherapy, but exercises can be continued. So one, I mentioned aerobic exercises. Second is strength training. So again, for that we don't need to join the gym. One can do self body weight exercises like squats, and then push-ups, wall sits, and then using small dumbbells at home. So all those things should be done about 2 or 3 sessions in a week should be enough.
Thank you, doctor. And the next question is, doctor, is the location of the lesions directly proportional to the... Mr. Balsubramanian, can you please mute? Thank you. So the question is that, is the location of lesions directly proportional to disease severity? And do you think people with more lesions have to go for more effective DMTs like Ocrevus or stem cell therapy?
Yeah, I'll take the first question first. So yes, the number of lesions definitely help us decide the severity of the disease, and so the choice of treatment. So those who have more lesions, especially active ones, they require highly effective therapies. So their Ocrevus may be useful. And then if you look at the first question about the location of lesion and disability, definitely. Suppose if the lesion is located in optic nerve, as Dr. Ritu said, it can affect the vision, and vision is one of the most important functions. So it may be just a lesion in one nerve, but the person can be handicapped. Whereas if you look at, say, lesion in the, say, some part of the cortex, so their person, many times we see that they don't have any symptoms. They come with optic neuritis only, and no other symptoms. But when we do MRI, we find lesions in the brain. So, but they have no symptoms. So in some parts of the brain, if the lesions are there, and the MS lesions are typically small lesions, so they don't cause symptoms. So location of lesion will definitely decide the symptoms.
Sir, can I request?
Okay. Thank you.
Hello? Madam.
Javed, please mute everyone.
Madam, Bala. Hello.
So please speak.
I am a bedridden patient for last 10 years.
Okay.
In MS.
Please go ahead.
Hello.
Yes, sir. Please go ahead.
I am bedridden patient for last 10 years because of MS. I am not able to go out or walk also. In that situation, what kind of suggestions I can get?
So, Dr. Sudhir, sir, do you want
I
to
think at this stage, there are no effective treatments for MS. So mainly you have to look for the physiotherapy and kind exercises. But
Mr. Balsunya, can you mute yourself to avoid the echo when doctor is speaking?
Okay, I'll mute it.
Thank you.
yeah, so what I'm saying is that all the MS therapies, they only prevent the next attack. So somebody has already become bedbound because of previous disease. There is no MS therapy that can make him, recover from that. And I also mentioned central nervous system nerves, they don't regenerate. So as of now, the treatment should be focused on the physiotherapy part. And that is where we have to work mostly. The role of medication is not there.
Thank you, doctor. Someone is asking about the myelin repair strategies.
I think it's in the research stage, so we can skip that. Yeah.
Okay, sir. And also another question about the gait issues. Someone is asking what is the most successful medication one can take for MS with gait issues?
I think companies do promote, but the most important thing is the physiotherapy. It is hard work, but more we exercise, better the gait becomes. So that is what we should focus more on. There are no effective medicines to improve the gait.
Sir, very important question is that can MS pass to their kids if parents have it as a gene?
The answer is no. See, if you look at research papers, there'll be some papers of genetic MS, but if you ask neurologists or if you ask other MS patients, then they will tell you that they have not got it from their parents. So if somebody gets the MS from their parents, then there may be a risk of going to the children. But I am already like 26 years into as a neurologist, but I'm yet to see a genetic MS. But yes, I agree, in the literature, there are few case reports, but so practical answer is no. If it is an exam question, we have to say, yes, it can happen in a very small number of people.
Sir, I would like to have one more question on the dimethyl fumarate. The questions are, there are two questions on that. One is that is dimethyl fumarate effective and is approved in India is number one. And number two is I'm admitted in the hospital and took 5 injections. It is not cured and I'm taking rituximab. And I think we'll get to this later, sir. You can just answer this dimethyl fumarate. Is it approved?
Dimethyl fumarate is approved for a long time. I think more than 6, 7, 8 years. Even before COVID, we're using it. So earlier we had only one company which was selling by the name of Tecfidera. But now we have many companies that sell dimethyl fumarate. So we have generic version which are much more cost effective and affordable. And it is available. Many patients are using it. It is safe.
So it is, I took dimethyl fumarate for 2 years. Suddenly I face all the symptoms back. Then I'm admitted in the hospital and take 5-day injections. It's not cured. I'm taking rituximab now. I'm okay. Sir, my question is why suddenly the tablet that was working for me is not supporting me anymore?
No, that can happen. So see, the disease which is mild can become more, aggressive over time. So that can happen. And that is why we have highly effective therapies like rituximab or Ocrevus in India. So, but we can't start that for everyone in the beginning itself because of the cost factor.
Doctor.
So, but we have to, that person is on the right line. So we can expect rituximab will help him avoid relapses in the future.
Yes, Sushma, are we waiting for someone?
I think her screen got frozen.
Screen was frozen. Yes. Yeah. Yeah. I think there are no more questions. Maybe Aarti, you can go ahead. You're muted, Sushma.
Sorry, it got disconnected all of a sudden.
Your
Sorry.
questions are over, Sushma.
Just one or two. This is to Dr. Namita, ma'am. Ma'am, you're there? Thank you, Dr. Sudhir Kumar. Sorry, I vanished because of the connection issues. Sorry. Yeah. Namita, ma'am, this question is to you. You were mentioning about the anxiety part, like there is continuous questioning about the self. What if, let's say tomorrow there is a commitment at 10 a.m. What if I cannot make it? What if the fatigue sets in? There are a lot of what ifs for many things throughout. I think this is something which almost all MS persons go through. How do we cope up with this kind of a regular anxiety, I can call it?
Yeah, again, a very relevant question, and it's not just related to persons with MS. It is today a common phenomena, and I called anxiety and depression the common cold of mental health, which keeps happening. That's how I term it to make it feel light. But on the actual application part of it is tomorrow is for tomorrow. Today, what I am doing here and now is more relevant. So if there's a meeting at tomorrow and what if the fatigue set in, what have I done today to prepare for that meeting or presentation, and what can I do right now to relax myself in a healthy way? The important part is anxiety is mostly futuristic, and many of us worry with the idea something may go wrong or something may not happen. But that doubt is the place where we need to inject the thing that it is not happening right now. What I can control and regulate or manage is the here and now, the presence of this moment. When we are able to pass that bridge, automatically tomorrow is never a question. It is a process. Till the time we are breathing, till the time we are waking, sleeping, whatever we are doing, we have to be present mentally, physically, emotionally. In the bigger sense, we call it mindfulness. So mindfulness is a good way to be aware of yourself in the here and now, in this very moment, which makes us feel in control, capacitated, and able to handle the what if scenario, because the what if is not happening right now. Does that help?
Definitely. I think we are living that, imagining tomorrow's thing. We are living that at the moment. So I think the mindfulness and reassuring that this is not happening right now, it greatly helps, doctor. Thank you. And thank you very much.
And lastly, am I disturbing? Yeah, I have a last question. Can I?
Sarita, please. Yeah, please.
Yeah,
I think
yeah.
This will be the last question. Yes.
Yeah. I'm asking you, the neurologist, about the usage of dial step tablet. I saw in the net that, I mean, when we use dial step tablet, it reduces the progression of the disease. Please tell me about the usage. Is it compulsory for about the usage of dial step tablet?
See, dull step tablet is not a specific drug for MS. So
Okay.
it is not used to prevent relapses of MS.
Okay.
And so So what the company says that it can improve the walking. So those who have walking difficulty or imbalance, it may improve the symptoms of those problems. But for the disease progression or to avoid new relapses in MS, Dalsep is not effective.
Okay, I'm actually MS. I'm in secondary progressive MS. So my walking is somewhat difficult only. I'm like in my home, I'm walking. When I'm walking more, it is difficult for me. Shall I use Dalstep tablet or no use?
It is not of much use. You can leave that. Focus more on the exercises and physiotherapy.
Oh, actually, truth saying, I'm not doing physiotherapy. So will it cause any problem?
You can learn exercises and do at home.
Okay. Is it important? Compulsory? Is it compulsory doing physiotherapy?
Exercise is important. Nothing is compulsory. People, they have become sedentary more and more now. So,
Yeah.
so now you have MS. If you remain sedentary for another 10 years, you might end up obesity, diabetes, high blood pressure, many things. So the choice is yours, but it is better to be active. Just 20-30 minutes in a day should be fine.
Oh, exercise, but what about physiotherapy?
Physiotherapy means exercises. You can do exercises for, there's something called strength training. You can watch videos on the YouTube and then do exercises to make your arms, legs, abdomen, back stronger. Just spend 15-20 minutes, alternate days. That should be enough.
Okay.
I think Harita, we are running out of time. I think doctor has answered your questions, and request everyone to please post your questions to our email address if there are any, because we are already running over time.
Yeah, last 1 minute. So can I stop the Dalstep tablet, doctor?
Yes.
Okay, no problem at all.
No problems.
Okay, thank you, sir.
Javedji, please put our email address in the chat box, please. Request friends to please post your questions to the email address and we will have them answered. We will send them to the doctors because we are running out of time already. And I would like to thank all the doctors for patiently answering all the questions. And these are something we don't get to really ask within the cabin of during the appointment time. So thank you so much for elaborating on every question. Thank you so much once again. And over to you, Aarti, now.
Thank you, madam. Thank you, doctor.
Am I audible?
Yes.
Yeah, I want to be audible because I want to thank the doctors.
Yes, you are.
Sunday has been enlightening, energetic, and eye-opener to all of us. Hearty thanks to this panelists who were here for us today, guiding the journey with MS. Most of us are actually in a denial and non-acceptance mode upon diagnosis or just simply not aware enough to cope up with MS. We now, after the session, are a little bit aware. We try to be aware, and such sessions are very much required. So takeaway today would be so many. Takeaway is too many, but I could just write few of the points. Eye is the window to our body and health. Early diagnosis and time treatment is the key to effective management. Goal of life is to be positive. Then the body function can operate positively. And learn how to say no as you want your life, the quality of your life. Focus on your breath. You need to be a star for the universe. Don't be a star for the universe. Be a star for yourself. It's a beautiful word. Beautiful. I think one should catch that out. And take care of yourself. Love yourself. And very important is exercise. Any type of exercise. It makes you going. It keeps you going. And this is what the take home was. And I thank the doctors once again for being here with us today on a Sunday morning. And it's lunchtime. So before everybody leaves, I want to request everybody to have a heart like this so that we can have a picture.
Aarti, ask everyone to show their faces.
Request, please switch on your video. With a smile, have an heart like this. And we will have this posted for the World MS Day and MSSI Hyderabad chapter 2025.
Thank you so much for laughing.
Javedji, have you taken it?
Yes.
Thank you once again, Dr. Sudhir.
Thank you.
Thank you. Thank you,
Dr. Ritu and Dr.
Dr. Namita.
Namita
Singh.
Namita, ma'am.